So good morning. My name is Mark Jennings. I'm Director of Housing at Community Access. And I have the honor and the privilege of introducing and slightly moderating the discussion for today. And you've definitely come to the right place in your choice of panels for the morning to learn a little bit about a new CTI model to really assist individuals coming out of hospitals and other institutions. And we all know that's a very critical time, that bridge. And, I'm speaking to the choir of individuals who know that suicide is one of the greatest times that this may happen, is during that transition coming from hospitals. And even we know that individuals who have a harder time transitioning may go back to the shelters in terms of, or decide that I just can't live here because I've lived on the street for 35 years. And so that transition period is very critical, and we'll learn more today about this model that's helping. So I want to introduce Mark Graham, who is the project director of Coordinated Behavioral Care's Pathway to Home program. Mark is a licensed clinical social worker, has completed his social work training in Manchester, England, where he started as an alcohol counselor. Moved to New York in 1999 and worked with the Partnership for the Homeless, initially as a program coordinator of their HIV housing program, and later as the director of NYC's Emergency Shelter Network. In 2005, he returned to his native Ireland to set up the country's first assertive community treatment program before returning to NYC to manage 6 ACT teams for Pathways to Housing. He's been in his current position at CBC since August 2014. Also would like to introduce Todd Barnes. So Todd is a BSN and an RN and MPH candidate. Has served for 3 years as RN on the Pathways to Housing East Harlem ACT team, as well as several years working for the Visiting Nurse Service, Visiting Doctors Program, providing home-based disease management and other care. He's now working with ICL Pathway Home Transitional Team since October 2015. Mr. Joey Drucker practices as a licensed social worker with the Center for Urban Community Services, working directly with tenants in supportive housing. He enjoys the person-centered approach in his work, and previous work has included individual and group work with vulnerable seniors, employment counseling for disconnected young adults, and counseling for kids and staff in and after school setting. He's earned a Master's of Social Work degree from Hunter College, where he's published an article, Redefinition versus Meaninglessness, Seniors Revisiting Purpose, and facilitated a discussion for male-identified social workers using a feminist perspective. Before changing careers, Joey practiced as a structural engineer. He also has a passion for yoga, meditation, the outdoors, and community building. And we also have Mr. Michael Greene, who is originally from Virginia, the state for lovers. And Michael has been living in NYC for several years. He has an associate's in arts degree from Ulster Community College in New York and completed his CASAC-T with Narco Freedom. Michael has experience in both counseling and support housing settings prior to joining ICL's Pathway Home Transitional Team last November. And so with that introduction, I'm going to move aside and let the show begin. Oh, one more thing, if you can just silence your phones, that would be helpful.
I leave my water here. Microphone. I'm never the best with microphones. I'm told sometimes I talk too loud or too fast, and then a microphone adds to the equation. So hopefully you can all hear me. If you can't, but by all means raise your hand and I'll speak up. Or if I'm speaking too close to this microphone, same applies, raise your hand and I'll step back. To start by saying thank you to Mark for moderating the session today and for the introductions. As someone who forgets names very easily, it's always helpful to have a moderator who shares your name. I'd like to thank you guys for joining us today at this session. It's a real privilege to be able to present on our Pathway Home program. It's a new program, as you'll learn. We've only been in operation for 8 months. But it's been a sort of very important program working with those individuals as they transition. And it's really nice to be able to share what we've done, but also really to sort of advertise it in a way to housing providers. Because as you'll learn, we really work with individuals in supportive housing networks and would like to work more closely with housing providers and receive referrals from housing providers. I'd also, just to give you a sort of a rundown, I get the fun job of giving you the history and the rationale for this project. Todd is going to give us a little background on the medical role within the team. Michael is one of our peers and is going to talk a little bit about the peer role on a CTI model team like this, and also particularly the role in sort of engaging with the individuals that we've been serving. And then Joey, I have to extend a thank you to as well, because he is not employed by us and we did not pay him to be here today. He volunteered of his own accord, but is one of the housing providers that we have worked with and where some of our clients have transitioned to. And he kindly came along today to share their experience. So to start, as Mark said in the introduction, I work for CBC, which many of you may know stands for Coordinated Behavioral Care. CBC is a health home, as you're probably aware. They were formed in 2011 and are unique in so many ways as a health home, in the way that they are not led by one major agency, as a lot of health homes are. CBC was formed by 40-plus nonprofits that came together at a time and recognized that there was a need for nonprofits to come together and form an organization that could provide care coordination care. The nonprofits are made up from some of the largest nonprofits in the city. They're predominantly coming from behavioral health backgrounds. They'll provide other services as well. And a large number are supportive housing, members of the Supportive Housing Network. And many of you are employed by agencies that are part of the CBC network. Part of the CBC's idea and model when they came together obviously was the health home care coordination. But there was also an idea that with the changing times in New York, healthcare and the health system, particularly mental health, that as a group of agencies that had expertise in this area, they could bring a lot to the table. And they looked for opportunities where to be able to influence some of the changes that are occurring within the state of New York. And one such way was the Balancing Incentive Program, which was a grant that was offered by the Department of Health. It was using Medicaid redesigned money to look at new initiatives to address some of the existing problems that we encounter in our healthcare system, and particularly in our behavioral health system. And CBC really, as a group, discussed what sort of areas there were in need for additional care, where were people sort of falling through the cracks. And that is where they came to in what we now know as the Pathway Home program. I'm hoping I'm going to do this right. Oh, there we go. Many of you will be familiar with the idea of a revolving door patient. Through your housing agencies, undoubtedly you've seen people come from state facilities or city hospitals and move in, and unfortunately within a short period of time return to a hospital setting. As a system of providers, there is so much care and support and offer to those individuals coming out, but something seems amiss in our system. That we still have a high percentage, you see here 11%, that return to hospital within a 30-day period. When you stretch that out over a longer period, that number increases dramatically. You start to see trends. The majority of individuals who are readmitted are male, 63%. The age group, you get that prime target of men between 25 to 54. And those who've had past hospitalizations, it almost triples the risk of them being rehospitalized again within a 30-day period. And so you have a system that has so much sort of on offer, from AOT to ACT services to housing residents, but yet we still continue to have a large number of individuals returning to the hospital, which led to this idea of looking about adapting sort of CTI to work with these individuals as they transition. And in doing so, as we look through the model of care, picking out the best of what is on offer now, and forming a team is not recreating the wheel, it's not reinventing anything, but looking where we're putting our emphasis and our focus. For those individuals who do come out, and again, Mark said you're preaching to the choir, which is always nice at a conference like this because you can relate to people. The factors for predicting readmission they would jump straight into your head. Housing stability. Obviously, a lot do get housing placement when they come out. Some do not. Some move into a housing arrangement that we as professionals think is great for them, but it's not a right fit for them. It's not the right borough for them to be involved in. Others come out in family support. The support isn't there that they need in order to maintain their stability in the community. Often we see, like some of the families that we work with, within the household, the family themselves, for various reasons, have little insight into the person's illness or are unwilling to be supportive in their treatment. Community supports can be absent. We can make referrals all we like, and often feel, I think, as we discharge people, that we've done a great job, that we have set something up for them to go and we have an appointment date. But unfortunately, a lot of people do not make it, and they don't take advantage of those community supports. Substance abuse really goes without saying. Unfortunately, with the individuals who we work with, there's such a high percentage of those who have substance abuse problems, and often we see their substance abuse leading them back into a hospital setting and then leading to a psych admission. Medical conditions can be similar. When untreated, an individual ends up in a medical ER, is stabilized there, and then often gets transferred back to psych because they have a known psych history. People check their psyche system. Daily living skills, just in the day-to-day management. I think we often place an expectation on individuals and feel sometimes that we give them a safe, warm environment to live in, that in itself is sufficient. But as we see often, there is a need, and case managers do a wonderful job of this in supportive housing programs, of working people through their daily living skills. But without the additional support there, it can often lead to a person's deterioration in the community. Social stigma associated with mental illness, substance abuse, prevents people taking advantage again of some of the services that are available, and then outpatient attendance. The key for a lot of people when you look about readmission rates is the number of those who make it to their outpatient appointments, and so many fail to make that first appointment post-discharge. Again, they get the slip of paper with the date, but getting to it can there's so many obstacles that can be presented, from not having subway fare to being unfamiliar with the neighborhood where the clinic is based. And I say that with having often got off a train in sort of East New York and not knowing which way to go, and all of a sudden it's not numbers, it's street names, and thankfully I have the advantage of a phone with a good old map on it, but without that it can be a real challenge for people. So our focus really was that there was an identification for a need for change. And you can look at different reasons why. You'll always get the push from a state perspective and a city perspective. Money comes down and boils down to it. It's very expensive having readmissions. They're identified often as readmissions that, I'm going to get the terminology wrong, unnecessary readmissions. Individuals that with the proper supports would not have been brought back into a hospital setting. And those are the readmissions that are often targeted by state officials, and rightfully so, that if the proper supports were in place, we wouldn't need to be spending our Medicaid dollars on those individuals in a hospital setting, which is obviously so much more expensive. The emotional cost, though, I think, as a social worker, and from spending most of my career doing direct client work, is really what hits home when you work with the individual and you see the effect of multiple hospitalizations on an individual. That you see the effects of institutionalization for some of the patients who are longer in the state hospitals. And then the stigma that becomes attached with that a person starts to, and I put it down, lower expectations and motivations, starts to expect that they're going to return to hospital at some stage. That they feel like there isn't, what's the point in motivating themselves? There's no breaking the cycle, that they're going to be readmitted. And some of that is the impact from our systems that I think when we look ultimately at change, it always has to be a systems change and a mindset. that sometimes with our care management programs, our PROS programs and stuff, often the initial reaction is they're decompensating, they need to go to the ER. And so how do you break that mold? How do you start to look at offering a different sort of treatment model? And that was the challenge for us, and where we came up with this idea of the pathway home model. As I said, so at the beginning, funding-wise, it is a grant-funded program from the Department of Health. For any of you who work with regulatory bodies, and I did for a long time with ACT services, grant-funded is lovely because you don't have as much regulatory oversight. It gives you a lot more flexibility in the work that you can do with individuals, and the sort of how you can tailor your visits and your interventions to your assessed need for that person. So I would stress that we are an adaptive critical time intervention model. We used it, and it's particularly its time frame as a guide for the work that we do. We also really focused on the community support component that is so important in a CTI model, as seeing that particularly in those first 3 months of getting involved in the individual's care. So our emphasis, and I'm going to go through the whole program model, does break down roughly by those months, that the first 0 to 3 months, we do provide a lot more intensive support. And then with that 3 to 6 month window, we pull back a little bit. And I'll talk more about that. We do shadowing with individuals. So instead of taking them and bringing them to an appointment and escorting them, we will follow from behind and see if they can navigate the subway system themselves, if they can save the money that they need to get themselves to that appointment as opposed to giving it to them. And then further pulling back so that we, in the 6 to 9 months, it's really looking about sort of stepping someone down. This model fitted very nicely because we were grant funded and we had 1 year. So it really was it really worked with the clinicians, and I'm sure they would agree that in a year's time, technically we won't be here. So we can't become this service that people come dependent on and rely upon. That, it really is programmed that we want this person to be as independent as possible, and particularly have the community supports at the end of those 9 months, because they can't rely on us because we will not technically possibly be there. So as a model, how do you go about creating those 0 to 9 months? What CBC did was they subcontracted to 2 agencies, and we created small multidisciplinary teams. We have ICL here today was one of those agencies. These teams are small. There's 4 to 5 staff per team. We have a nurse, social worker, peer, and it juggles a little bit then. One team has 2 peers, one has 2 social workers, and then we have a nurse practitioner who works with us part-time. So it's very, for those of you familiar with ACT, it's very ACT-like in nature by the makeup of the team. And, Todd will speak a little bit about the sort of, from a nursing perspective, really sort of focusing our efforts not just on behavioral health, but on physical health as well. We see people in 3 boroughs, the Bronx, Manhattan, and Brooklyn. So we are pretty much spread, and it's with 2 teams, it takes a lot of organization when we receive referrals because people end up living across those 3 boroughs. What our emphasis has really been from the beginning is our responsiveness to the state hospitals, to the city hospitals, and to those who, like yourselves, are in a housing setting, is that within 72 hours, we will come and screen the individual for services. And a little further on, I'll go through our criteria, which is pretty much minimum. But our main focus when we screen is one, that the person wants the services. We're not mandated, we're not ACT, we're not AOT treatment. And so there has to be, and we found with our success, a level of buy-in from the individual. And then we aim for and really push, if the person is in hospital, for a minimum of 2 visits at the hospital. This is easier if someone's in a state facility where they've been for a long time, much more difficult if they're at a Bellevue or a Woodhall because there's a pressure to discharge. But our goal is, and the reason why, is the development of a therapeutic relationship. That if you can form that within the hospital setting, meet the person there, it makes that so much easier than having your first visit knocking on someone's door in the community. And we've seen that through health homes, and I've personally seen it through ACT. People are obviously very suspicious. I would be. If someone knocked at my door and said, "Oh, you were referred to our program." So we really make a point and an effort at seeing the person in the hospital. It allows us to be involved in their discharge planning. And that, to me, is key. And when you look at supportive housing providers, some of our individuals are returning to live in a supportive housing. And so it allows us to start working with the housing case manager. And often, sometimes, to be an additional voice to say, you know what, the person's not ready. And so we push back and have pushed back sometimes at the hospital setting to say, you need to keep them a little bit longer. You need to sort of like, have you considered this? We'll bring our nurse practitioner in to assess as well. But we feel like we can add to the voice of a family member or a community provider with the hospital. And then we focus on doing an immediate needs assessment. Some of you, again, were probably very familiar, but it's really asking the individual, what is it you need? And so we've had people say they need books. We had a woman needed a water filter because she was very paranoid about the water from her tap, so she wanted to filter her water. And we had very generous sort of enhancement funds that we were able to utilize to meet those immediate needs. And I know that myself is a luxury, but it's been so critical in being able to form a relationship. If you provide someone with something and they get an immediate response to something they asked for, to be honest, they don't care about whether their medication went to the pharmacy or if they're going to go to this program. If they want something that's basic. We had a guy who was discharged from a hospital in December in flip-flops. And he was like, I just need boots. And it was a very easy ask, and it was very easy to accommodate. But it meant, for some individuals, it's like, wow, you actually did something for me, and you listened. So it's an important part of our treatment model. So our visits then go into the community. This is where we come back to being a little act-like. We, wherever possible, will escort the person home. We found this is really another part that's a very sort of key part of our intervention, to be able to be there at the hospital when they're being discharged. And whether it's with one of our own vehicles, or more usually it's with a taxi service, bringing a person back to their residence, or whether it's a family residence or whether it's a supportive housing residence. It allows us as a clinician to get an opportunity to see where they're living too. And to see, sometimes you come back and the place is a pigsty, and you can start to offer some support to make that housing stable again for them. And so that is our primary focus, and I would say probably around 70% of the time we're able to escort a person home. Our other primary focus is initial behavioral health appointments and PCP appointments, going with the person, finding out where that clinic is, using our resources if needed to get the person there. If a person fails to go, being there at their home and saying, okay, well, let's sit and reschedule this, and making that follow-up appointment. It's not just about ticking a box that someone got there. It's often being there as an advocate for them at that first appointment. I hate to say it, but sometimes it's helping them stay because they have to wait so long to be seen. So you can buy lunch for someone. But you can be a support. You can be there to hear what the doctor's saying. If they've expressed concerns to you about their medication, you can raise that for them if they're unwilling to do so themselves. And then also you learn when their next appointment is. We can then program that so that we can offer reminders. Where possible, if a person doesn't have a phone, we'll purchase a phone for them so that we can offer reminders to them through text messaging to allow them to as a reminder service that these appointments are coming up. My hairdresser does it, so, and it works because I never remember when I made that appointment. Then we provide ongoing community support. Particularly those first 3 months is the intensity that we offer. We see people, again, grant funded, so it's very nice. Sometimes we'll assess that a person that needs to be seen once a week, but there are some people that we'll see 5 times a week. We work on weekends, and so that particularly for those Friday discharges, we're able to go in to see someone on Saturday or Sunday in their home instead of having to wait till a Monday to be seen. And obviously, like most outreach teams like this, we have 24-hour coverage. We work with medication and benefit reconciliation. obviously very important. We work with one particular pharmacy if a person wants to, who will come in and take all their meds, whether it's physical health and mental health, and then go through them. They'll call the doctors on the medication things to see if they're active medications. Are they still on these medications? And they'll do that work for us as part of a pharmacy service. Again, with medication, we don't prescribe. Our nurse is there as a safety net. So if a person fails to make an outpatient appointment or their Medicaid is inactive, we can prescribe their Prolix and our nurses can administer the shot, but it is not our primary goal, it's not our primary focus. But just on I suppose a little side note of one case we worked with, back to our nice sort of like enhancement dollars, we had a woman who was in a city hospital who had had 3 admissions for suicide attempts. And she would decompensate, suffer from major depression, would decompensate when not taking her medication. Her motivation when she saw us at the hospital was that she forgot. It was her memory. She was an older woman. It wasn't intentional. She did want to take her medication. And we were able to, or one of the nurses sourced a device that he was able to place her medication in, a 2-week supply. And if she failed to take it, he would get a text message and an email, and so would her niece, to say that she had missed a dose of her medication, and they were able to contact her to advise her that you missed your medication, you need to take your dose. And for her, that was January, she's still out of the hospital, and so it's a small thing, and I think a lot of what this sort of innovative grant was about, seeing is an expense like that worded so it avoids the hospitalization. Our links with community support services is key. We look, and Michael's going to talk a little bit about one gentleman who was going to one treatment program that he didn't like, and how you make that change, and saying, it's all right. Other programs may be more suited to what you're looking for. But our goal is to really get people linked with their community supports. Again, we pull out. So between their housing networks, their behavioral health, but other supports that they need, whether it's family members in the community. And then we provide support to housing care managers and family members, and Joey will talk to you a little bit of that. We've been able to, a big focus of ours is really working with those individuals who've been hard to place or who have difficulty retaining their housing in the community. So if you're working with those Pop B populations, say coming from a state hospital, who on paper look like they pose a lot of risk, we would want to be there to offer extra support for that person. The service is free, by the way. And so we would work with that individual, but work with you as a housing provider. So if they need additional supports in the home in order to be able to stay and retain that housing, we've worked with hoarders and been able to pay for some specialized treatment there. We've been able to, we could put in rails if someone has a disability, and that's proving an obstacle to their housing. But our goal is really to work with the housing case managers too, to be there, like if they start to see or suspect someone's decompensating, is that they can contact us, that like almost like mobile crisis in a way. They can call us and say, hey, we're concerned, and that we'd be able to send someone out, our nurse practitioner if necessary, but initially certainly one of the team members that same day to see and to sit down and say, look, what's going on here, so we can work through what the issue is. Oh, this is up to Todd.
Hello. I want to acknowledge that the clients we work with have many issues that they face. Physical health is one of those issues. Oftentimes it can take a backseat to something that seems more pertinent at the time. However, we chose to focus on it as a program because chronic health issues are a global epidemic. The burden of disease worldwide is shifting from infectious disease to chronic illness. This is magnified within the population that we work, severe and persistent mental illness. We all have heard stats and probably know them by heart. Life expectancy for our population is 10 to 25 years less than the average person. Incidence of chronic illness like cardiovascular disease, respiratory illness, lung cancer, diabetes are higher than the average person. You know, in short, the individuals we work with are more sick, they're dying faster, and they're dying sooner than the average person. So obviously, it is an issue that needs to be addressed as a system. I think we're seeing some changes in the Affordable Care Act and with accountable care organizations. But in terms of our team, you know, in the 0 to 9 months, the 6 to 9 month timeline, we really focus on enhancing the quality and the connectivity to the PCP or specialists in the community, and also focus on trying to build the foundation for talking about some of the lifestyle changes that go along with the chronic illness that we see: smoking, nutrition, exercise. Those are things that take a long time to work on and to change in us as individuals, and obviously with our clients it's even more of a challenge, or it can be. So in terms of enhancing the quality and the connectivity of our clients to the medical providers in the community, it really starts with, as Mark mentioned, when we see ideally our clients first in the hospital, in addition to having an opportunity to establish a therapeutic relationship, it's really information gathering time. It's really important. As a nurse, I like to go in and be able to look at the history that they have and see if it seems like they're missing anything. If I can collect any information that's going to be helpful for the primary care doctor on the outside, I'll collect it at that time, because once they get discharged, you know, forget about it. So that initial acquisition of health information is critical, and it can be a barrier in terms of just interviewing the client and obtaining a health history from them. It's a challenge. Once we get into the community, we like to escort them and attend their first primary care appointment. I feel that it's important because you can really be that extra ear for the doctor as they're explaining to the client what's going on, and also you can educate the doctor on the psychosocial kind of situation of your client, the barriers that they're facing to continuing to come and see them and to be med adherent, to address their various issues. So, you know, in terms of barriers, the kind of outpatient silos, the lack of coordination, unfortunately, is kind of inherent in our system. We try to work around that by being present at the first appointment and really focusing on coordinating and planning for when we're no longer going to be a part of this client. Is the doctor going to know who to contact if there's an issue? Does the caseworker or the long-term kind of support in the community, do they know exactly what's going on? And our goal is to kind of assist, you know, as housing providers, assist the case managers there in having all that information. And as a nurse, I'm looking to, you know, educate everyone I come in contact with about what I feel is going on. Another challenge I want to mention in terms of barriers is just the role of the nurse, which I'll talk about in the next slide. Is a non-traditional role. It's different. It's hard to plan out your day and know what you're going to talk about with our clients, and it can be a challenge in terms of hitting all the points that you want to hit, you know, thinking about the problem in a traditional way. So you have to be creative, and you have to work around the issue. Briefly, critical success factors, as I mentioned, education is key. Education to the client on their illness, diabetes education, educating housing providers or caseworkers working with people on coordinating care, and also when is the appropriate time to call EMS versus send someone to their urgent care provider. You know, one of our goals, as we'll talk about later, is decreasing ER utilization that's unnecessary. And a lot of times I've found that, you know, to be safe, housing provider, you will send someone to an ER, and that's to kind of cover yourself. But there's room there to make a informed decision about, you know what, I actually think, you know, this person has a doctor that's close by, we can call and send them in there, prevent an ER trip. And lastly, I would say, you know, I've touched on coordination, client-centered approach. You know, at the end of the day, we're all approaching our clients as individuals. We're treating them holistically. They're not an illness. They're not a mental illness. They're not a physical illness. It's something that's a part of the larger spectrum of what we're trying to do. And we're trying to enhance their connectivity to community supports and, you know, build a foundation for them going forward with the hope that they'll be able to stay out of the hospital and in the community and do well. And just briefly, I talked about the nursing role. I mentioned the importance of intake and screening, having a nurse involved early and gathering that information is, I found to be crucial. And just the whole holistic approach, you know, thinking about the person in terms of the housing that they're going back to, the needs that the physical needs that they have, but that will take precedence over, you know, them thinking about their diabetes. The role of an educator, educating your colleagues, educating the client, educating everyone you come in contact with. I have stepped in for our clients who need extra medication management. Mark mentioned the medication pill dispensers, which they can be helpful in the right setting. And I've stepped in and done IM administration for people who they don't make it to their outpatient provider, but we're really a stopgap in between them working with us and working to get them into like an ACT service or some kind of increased level of community care. Ongoing safety assessments are key in terms of assessing the safety and risk of harm in the community. Nurses often do this in the hospital inpatient setting as well, so it makes sense to do it and be involved in the outpatient setting. And then lastly, medical case management, and that should be medical home visit. I have tried to really stay on top of my clients who have more severe medical issues in terms of just coordinating, calling everyone involved, and then also making a home visit to see how they're injecting their insulin, to see whether they're managing their meds properly. Really my experiences in mental health, but also for VNS doing medical home visits, and so I've tried to meld the two together, and so that's kind of a picture of what the nursing role is.
So to give you just a sense of, I mentioned earlier that our eligibility is really open. We are targeting individuals coming from long-term hospitalizations. And so obviously you can work with, there's so many individuals who come out of hospitals on a day-by-day basis, but we're really looking just to sort of to make it a little smaller pool, those who've been in hospital 15 days or more. And so there's a lot of sort of housing providers who are working with that population. They're coming from state PCs, state operated community residences. That's the majority, and you'll see a slide of our referrals. So a lot of those are individuals that housing providers are already intaking. They have to be a Medicaid recipient or eligible for Medicaid, and difficulty maintaining or obtaining or maintaining housing in the community, and as I said before, open to additional support in the community. And so it's a very sort of simple eligibility criteria, because we really wanted to sort of really hit those individuals without having to sort of like, it's not cherry picking in any way. We just wanted to work with those who had these difficulties in the past and are really been in hospital for a long period of time. What I would say to housing providers is that if you have people who've been living at one of, say, your supportive housing programs and have gone into hospital, we would, for those housing providers, it's like start the referral process then, talk to the social worker or contact myself, and I believe in some cards here, because we would like more referrals from housing providers. Because, as I said, this is a free service. Because we do not bill Medicaid, it's grant funded, an individual can be going to a PROS program. They could be receiving other Medicaid funded services. The only one is ACT. If a person has an ACT team in place, we would not take on their case. because ACT technically is doing what we do, and sort of the person's been identified as needing it for a longer than a 9-month period. And the other thing I would say to providers is, at the end of 9 months, will this person with this support be able to manage, be able to link with community providers? So sometimes someone with dementia, say, who's an ongoing, unfortunately, progressive illness, it's not someone we would be really suitable for working with. So you can't really see that. But our referral sources, and the majority have been, 65% really have come from the state facilities. The state, and if you're not familiar, you obviously have the hospital, but on the grounds of a state facility is what they call their community residence. And a lot of individuals go to the community residence before being placed in one of your housing programs. And so we could take some people directly from the hospital who are going back to the community, but a large proportion have also come from the community residence. And when you see some of our stats and data, the state considered it as a community placement. And so our involvement we're taking people on appointments then. So some of the data includes that, and I'll identify it when you see it. 6% at the moment are only coming from our community providers, and obviously that makes sense when you think we're working with people coming straight from hospitals. But most of the people coming from hospitals are going to a community provider. They've interviewed at a residence. And so, I was talking to Mark at the beginning. We have a couple of people who are living in community access who came from one of the state facilities. Pretty much anyone coming from a state facility to one of your residents in those 3 boroughs of New York City should be considered for this program. You've nothing to lose in a way. So that's my little plug. And then primary diagnosis is what you would expect. 50% of the people we're working with have schizophrenia. 34% of schizoaffective disorders, 11% have a bipolar disorder, massive depressive or major depressive disorder is 4%, and then an anxiety disorder is 1%. Very similar to what you would expect coming from these hospital settings. Just to give you a sense of our program goals, when you write a grant, you have goals. And ours is really to reduce the length of stay that someone is in the hospital. That's why we did a lot of outreach to the state hospitals for some of their long-term patients who perhaps were waiting for ACT services or some other support service before they could be discharged, that we could take on that care. And with the hospitals as well, while if you live and work in New York City, for ACT services or the community treatment, there's a long, long wait list. And so we have acted as a bridging service for those individuals who need that level of support coming out, or it's deemed by the hospital and the community providers that they do, that we would offer that support service whilst they await their ACT assignment. We can work in conjunction as well with a health home. If your client is living in, or is a member of a health home, that wouldn't rule out our services. Our goal also is to reduce ER visits and readmissions, sort of as Todd talked a little bit about, by getting involved in the physical health issues, by really starting to develop our links with the community housing providers and family members. We often try to make ourselves the first port of call, that we would be the phone call that maybe could prevent someone going to a hospital. Obviously, increased attendance and engagement with outpatient providers goes hand in hand with any sort of CTI model, but also it's has a great impact on whether someone is going to continue to do well in their community. And then overcoming barriers to obtaining and retaining housing. I spoke about a few, and Joey will talk about some more that we've experienced. And linking with appropriate community support networks. And it's probably a nice little introduction to Michael, because he's going to talk a little bit about the importance of really linking people with supports in the community that they want to be involved in, and not being afraid to make a change when it comes to that, and the person saying, this isn't the right fit for me. But before I do that, just to give you our outcomes. So of those individuals we've worked with, 92% attended their outpatient appointment within 30 days in the community. That's a mix, again, with people living in community residences and those living with family and supportive housing programs. The next slide, it should be within 90 days, but 75% of the individuals had a PCP appointment. If they don't come out of hospital with a PCP appointment set up, that's one of the first things that we do for them. Again, knowing our time limit is to establish a PCP appointment date so that we can make sure that they get to one. And our goal is to have them do so within 90 days. It's more, behavioral health is always within 30 days, the appointment set, but PCP is not. Our admission rate is 8.2%. And when you compare with the first slide, it doesn't look a dramatic difference, but there is a difference in the population that we're working with. We're working with the more long-term, institutionalized, mentally ill individuals. And so our reduction, even in that population, in some ways is, we're proud of, to put it that way. But we're also only operating 8 months, so it really is kind of like we're an ongoing data collection process. And then of those who left and moved into housing, 90% had retained their housing at the end of April. And of those who didn't, I think there was, for those who didn't retain housing, included those who went back to the hospital. And I think we had one gentleman move to a homeless shelter. So that's our initial findings. Do you want to add, Todd? No? So Michael's one of our peers on the team. I have always had an appreciation for peers and what they bring to a program. I often feel from previous services that they don't get the respect that they deserve on our teams, and their opinions don't matter in some people's minds, but I've often tried to fight against that, and we're very fortunate to have Michael and a colleague of his, Gary, on our teams, and they bring something to the table that Todd and I and those of us with licenses can't. They have an ability to connect and have proven to connect with individuals on a level that I wouldn't be able to, and their input has been valuable to our program, and peers are a key component of our program. I think a key component to its success as well. So I'd just like to ask Michael to say a few words about his experience.
Morning. You know, I didn't start getting nervous so he mentioned my name. Just sitting there relaxing, you know. Oh boy, he said to breathe. I gotta breathe. It's kind of out of my comfort zone right now. First, I'd like to, thank the director of my program for providing me an opportunity to share with you guys what I do. And it's pretty rewarding. I'd just like to state from start out with that, we want to establish a partnership with people, with the housing providers, because from my experience, I've learned that decompensation and recidivism starts mentally when they leave that institutional environment. It's like they in a cocoon, protected environment. And, to come out of that type of institution or that type of environment, it's nerve-wracking, and the partnership has to come from both our parts, because I believe your objective is to keep them in an apartment. Our objective is the same also, to keep them in that apartment. But with that comes challenges, certain challenges to keep them. You have to identify, first of all, when I got so much to say. Appreciate it. Thank you. Go to my notes for a minute. Just a couple of things I wanted to just touch on. Another thing we like to establish with the clients is a trust thing. They need to be able to trust that we're there for them and be consistent. If we tell them that we're going to do something, then we do it. Stand by your word. Another thing that I've done with the clients, I give them haircuts, because I know when you look better, you feel better. Mental health goes with, physical, well-being, your appearance. When you look good, you feel good, naturally. There's a lot of good-looking people out here. And I should have known this was serious when I seen Todd in the suit today. I'm sure this guy's my man. All right. You should have known. So as I mentioned, it's about a partnership, you know, and I like to, also let the clients know that, you know, that I can identify with you. You know, I share your pain, you know, there's a part of me that wish we could take everybody into the program, but it's unrealistic, you know. And another thing that I've learned that they need, that they will need is, activities, you know, because I have clients that just sit in the house all day, and it's depressing. When you go in the house, you can sense the level of depression, you know, not just cleanliness, but just, you know, the lights out, this, and they're not motivated to do anything. So it's been my responsibility to assist and motivate the clients to want to come out the house, you know, even when it's raining outside, it's nice. You know, just come out of that environment. And they need to feel that they're safe. They need to feel a sense of stability. So when I see a client, you know, I make the attempt to let them know that, it's for, like I said, consistency. If I'm telling them to show up that day, I'm going to be there. And the partnership is so important with housing providers. I think Todd or Mark alluded to that there's, some people are quick to send them back off because they believe they decom. Nah, just, you know, call somebody, call their peers up. Because it's not, everything's not a readmission. Every instance is not a readmission. I think the cost, and I believe we talked about it, the cost of putting somebody in or keeping them in an institution is much higher than keeping them in an apartment or assisted living environment. Got a lot of notes anyway.
Can you go to the next slide? Can we go to the next slide, Mike?
Oh, I don't.
I can click.
Oh, fancy. Okay, my client. I have I have a couple of clients that I can share with you, but this is one client in particular who I've had a lot of success with. When I first met him was in the institutional environment, and initially it appeared like maybe we can't work with this guy, you know, but who am I to judge who we can work with, who we can't work with? It's not my profession. But I suggested to the staff at Pathway Home, let's give this guy a chance. Anyway, make a long story short, met him in an institutional environment, helped him transition to assisted living environment, and you know what it is? It becomes like some clients doesn't necessarily have to be rehabilitated. Some clients have to be habilitated because they've never lived on their own, never used a stove. I mean, the things that we take for granted, daily living skills that we take for granted, is so important. So, you know, my role varies because I have to be a caretaker. I have to, you know, and I go over there and I have to provide life skills information to this particular client, and he's getting it. It's slow. It's a process. You know, he's been in institutions for like half his life, and he's in his 30s. So more than half his life. So to expect this individual to, you know, make that acclimating, you know, transition into the community, it takes a lot of work and effort on everybody's part. And it is a team approach, because I can't do it alone. It's a team approach. The housing providers, you know, be patient. You know, give them an opportunity because, like I said, there's a lot of clients that have never cooked, don't know how to shop. You know, these little things that we take for granted, they just don't have these skills. So, you know, once again, I can ask you guys to exercise a little patience and work in partnership and communicate. That's a big thing. We got to communicate with each other. share with each other, listen, okay, because you may make a home visit and see that the client is not doing this, that, and the other. I make a home visit and the client it's a day-to-day thing sometimes. You know, there's a lot of us who may be a handshake away from being institutionalized for whatever reason. And New York is that kind of state that has, you know, it's a very hurry. I'm from Virginia, you know, it's slow motion. But New York, I mean, my point is that, you know, it's a struggle. It really is a struggle, and I have to exercise a lot of empathy and patience, you know, with the clients I do. And it's rewarding because when you see any level of success, it's rewarding. If he did his laundry that day, it's, you know, take the little things and you know, raise the bar because it means a lot to them, and we take it for granted.
Thanks, Michael.
I appreciate it. God bless you all. Thank you for coming out.
You want to move it on one, too? Yeah, I'll just use this little mic here. Joey, you want to take the... Sure. So Joey works at CUCS and has worked two moved back to live at Joey's residence, and he kindly, as I said, came to sort of share one of those stories today.
I wanted to touch briefly on the first story that introduced me to Mark and his program. It was a gentleman who was hospitalized, and to say that he agreed to the referral to Pathway Home, like, no way. There's no way either of these clients were going to agree to it until they met the people they were going to be working with, and it was just so great that your workers came to the hospital to meet the clients, and they realized what they were getting out of it. So, and for the first gentleman that I worked with Pathway Home, he is approved for ACT, but an ACT team waitlist could be a year or two. So Pathway Home, it's a really great fill in that time. But I'll speak about Miss Smith. She's 7 years old, white, heterosexual female. She's very religious. She's been in the building for 10 years. And I never expected to stand in her apartment until Mark helped connect her to services that would deal with the hoarding. She's extremely intelligent. She's very sweet. She means well. Really no problems in the building interpersonally. She has problems with ADLs. She has very strong smell, doesn't shower, doesn't change her clothing. So that was something that would put people off, but she never harmed anyone. Extremely isolated. She's divorced from a young age. She had a mother who lived in Florida who was still supporting her long distance. Her mother lived till 99 and was still sending little bits of money here and there, but she passed away, so she really has no connections. She's very frail. She walks with a cane. She walks stooped over. She's really like a target in the community. I worry about her all the time. She'll cross the street in the middle of the street, and cars stop and honk, and to have an escort for her is really amazing. In the past, Section 8 recertification has been really difficult. She was referred to APS, I think it was about 2 years ago, was approved, had a deep cleaning through APS. But I think a lot of people don't understand that Adult Protective Services, they can't just do what they want to do. They have to have, the person has to agree to it. So a lot of what happened was there was boxes stacked to the ceiling, things were kept. I think there were still like 8 huge garbage bags thrown out, but the room was still completely cluttered. She has a little bit of compulsion to cover everything with paper towels, presents a fire hazard. So let's see. So the APS deep cleaning happened. There was a court stipulation that the landlord would inspect her apartment every month. But again, she had to pass requirements for fire inspection, so the floor had to be cleared. It didn't deal with the cluttering problem. So, Mark, could you go to the next slide? So, right before she was rehospitalized, I had asked APS to do another deep cleaning, but they wouldn't. They called it organized clutter. Basically, the stacks of boxes that they had put up haven't moved much. I mean, she hadn't touched any of those items. And they said it wasn't high enough to present an imminent fall risk from the boxes. And really, it didn't work last time. So I didn't think there were any other options. Then she got lice. So major infestation, lots of worry about it spreading to other tenants. And really the only way to deal with lice that we could find was a hospitalization where a person gets deloused. So that took a couple of times for that to come through. And she still wasn't admitted to psych, came back home, had a couple of falls. So she has a history of cellulitis, a number of health issues, vitamin deficiency. So she fell, went back to the hospital, and then got moved to psych. She had agreed to medication. She only took medication because she thought it was required for her housing. No insight into her mental illness. So she gets back into psych. They get her on some new medications. They start helping. And the first day she got there, I was talking to the social worker about Pathway Home. Luckily, Bellevue knows Pathway Home quite well, so she was already planning for that referral. So the biggest thing to getting Miss Smith home was dealing with her apartment. She wouldn't agree to a low-cost declutterer that we have through the building. APS wasn't available. Pathway Home has some significant funds available. And if I would tell you how much it would cost to actually declutter, it was a little jaw-dropping, but it was available. This person was able to come 5 different times and work with Miss Smith. She met with her before she started cleaning. She came back, she had a gift of paper towels. She opened up every piece of paper, was willing to do that deep work that I think deserves all the money that she made from the cleaning. And the result is she agreed, Ms. Smith wanted to throw these things out. She just needed the help to do it. I think they found over $1,500 in cash in pieces of paper, in paper towels. So her biggest stress right now is, what am I going to do with all this money? For both the clients that have come, that I've come into contact with Pathway Home, I really never expected to stand in their apartment. And just this morning, I was in Ms. Smith's apartment, talking to her about medications and all sorts of things that we talk about. And the work is still going on. I think we're just 3 months into it. Todd has visited. There is primary care on site where I work, but Todd is able to help Ms. Smith believe in the work that's already going on, agree to the appointments. It's another opinion to be given that she needs a lot of encouragement. I wonder how independent she can ever be, but this is a really big first step. And again, I just want to go back to the buy-in that I never would have guessed that either of these clients would have agreed to it, but they did, and their lives are much better right now for it. Thanks, Mike.
Excellent. So you've heard a little bit about the supports that are provided free of charge. Sounds like something that I'm glad we have and we may utilize more at Community Access. And we want to just open up the remaining time for any questions that you may have.
How you doing? I got a question for Mr. Greene. In terms of like the CTI model is like a 9-month process, right? Roughly. Does, Mr. Greene, do you stay engaged with them throughout all 3 periods or when those periods end? How does that, because as you said, you know, there's a gradually reduction in the level of engagement. Do you gradually pull back with how you engage and work with the folks who are assigned to you?
Thank you, I appreciate that question. If I have, thank you. If there's a particular client that, I believe that we can reduce the services based on any level of success, we have, 2 staff meetings a week, and I don't unilaterally make that decision on my own. I bring it to the team, and then it's decided whether or not, you know, based on the level of success we've had or unsuccess we may have had with this particular client, we may either it's a gradual discharge process. So if we were seeing them maybe 2 or 3 times a week, we'll start seeing them maybe once a week or twice a month. You know, it's gradual. We don't just shock them with, you know, say, hey, we done. You know, we give them an opportunity to, you know, and also we offer them home health, which is once we stop, you know, we still want somebody in place in their life to continue to monitor and assist with, you know, anything that individual may need.
The only thing I would just, add to that is that, you know, as Michael says, we meet twice a week, and we review all places that we work with. I think even us as staff struggle sometimes going like, they wouldn't be able to make it on their own. And I've heard that from staff members, and we're like, well, let's give it a shot, let's try. And we've had people like, and then we'll call the clinic to see if they made it. And because we have to sort of prepare for that fact to see if they can do it independently. And if not, if they haven't made it, then we can explore why and work through it. But
I've got 2 questions. After the 9-month period, and let's say 5 months go by, 6 months, and the consumer is maintained and then it's bountiful, do you come back, you know? And also, after the 9-month period, do you have a time factor where you still monitor that person, you know?
yeah, great questions. And we're in month 8 at the moment, so yes is the answer. We do what they call sort of a reactivation. And so if you had someone that you'd been working with and we had discharged, and there's no time limit on that. If the worker calls me up or Todd or one of the staff and says, look, Joan isn't doing well, could you guys revisit? Yes, we can, is the answer. And it's, the second part with sort of, I have to say, I mean, again, with the 9 months, that is the CTI model. We kind of have adapted that to what we're seeing on the ground. So there are some individuals after 3 months, we're like, it's redundant. There's no point us remaining involved for another 6 months just because, you know, some model says like that we should. And so that's where we've sort of adapted what would be sort of seen as the key, some of the key features of CTI. And so that's where, you know, there are differences, so.
So I want to make sure there's other folks have an opportunity.
Okay, I have a question. This is for anybody. Once you guys take the client, right, and then they've completed the program period, after you disengage, have you ever took another client, the same client that maybe be re-hospitalized, something like that? Is there a policy against that?
No, I mean, we would, again, it's sort of, we would take them back. We had a guy who moved to Chicago and then came back to New York, and we took him back, he called us. So it doesn't have to come through, again, this is because it's grant funded at the moment. We don't have to wait for a referral to go through a SPOA process or stuff like that. We can reactivate it ourselves.
You said that there's a requirement for a hospitalization admission within 15 days. Do they currently have to be hospitalized, or could they have just come home a month ago prior?
That's a great question. The way the grant is written is for people who have 15 days or more in hospital. Where but then someone hears about this program and goes, but again, Joan just left hospital yesterday and she was there for a month. Then I would say call me, because I think there's a flexibility. If it's 2 months ago, unfortunately, no. I mean, we have to unfortunately draw the line in the sand. But if it's been in the last, say, 2 weeks or so, I would say yes.
I want to know, through the time, if they're deactivated, does it start from the time period that they was actually deactivated, or does the time actually start over from the first month? To get
That's,
them
yeah, I kind of, I'm flexible with these things. I just kind of roll with it until the person's stabilized again. I don't have a time clock that, yeah, but it's a very good question.
So,
Yeah, hi, my name is Mike Golub. I'm the CCSIU and been training on CTI for 8 years now,
Yeah.
working closely with Dan Herman at Hunter. But my question was to Joey and to everybody, just in terms of buy-in,
Mm-hmm.
was it the in-reach that you did that was the buy-in? Or if you had this woman come out and then, she was at her home and then you offered the service to her, would that have been the same result? Or is it because you went into the institution, into the hospital, that really worked? And how long would you do that for before she's discharged?
Yeah, I mean, it's a great question. I think I could see success either way, but particularly in the hospital setting. But what I talked about buy-in at the beginning and stuff, and just because someone says no to a hospital social worker or to a housing provider, we often will go out and just do an engagement, just talk about what a program is. There isn't forms to sign and stuff, so you sort of explain the nature of the program. And so that can sort of work either way, and I think that's where the buy-in comes. We'll normally go 3 times to meet with the person. Again, the buy-in can be on very simple levels, that just having a coffee with someone can often be a great sort of engagement tool. And it doesn't have to be a conversation about mental health. It can be about the Oscars. It can be about, what was on TV last night. And so, and I think that's where the staff, with Joey's clients, made some inway in getting that connection. So.
Can I add to that? I would just say, anecdotally, I feel like meeting someone on the inpatient setting is helpful. One of the things that we want to start measuring, we started last month, I believe, is recording who we are able to engage with on the inpatient setting versus not, and to kind of measure and see if there is actually outcomes that are different. Anecdotally, though, I feel like it is important.
backward.
It's just a two-part question. One is about the training that you receive, and specifically around how you're engaging with clients. So, why is this model kind of more successful just in terms of the engagement strategies? And then the corollary to that is there any monitoring that you're doing around fidelity to the model, working with a consultant or developers or something like that?
Mm-hmm. Take part 2. Sure. I suppose the engagement side of it comes, we're very small teams. And so when we get a client, I screen all referrals as they come in to sort of identify who perhaps on paper they might work best with. And I'll often talk to a hospital social worker in relation to, from your experience with the person, do they work better with male, female? Is there a preference that they have? And doing our best to try and link someone with that. But we haven't sort of followed and adapted like a training model around the engagement process. Our approach has been very much, we don't go in with any paperwork. Someone said this to me, it's like, well, what do they sign to be part of your program and stuff like that? We don't go with anything. We go in and we have a conversation. And, as Todd said, it's really trying to do that. I hate being there when it's their discharge planning meeting and here we arrive and stuff. And so it really is, I suppose it's a very, just trying to be as a human approach, just to form a connection. So, and do you want to add about the data side of it?
Yeah, I mean, we have a consultant that we're working with to clarify and really break down exactly our model and in terms of the fidelity to CTI it's something that we're in the process of developing. You know, this conference is occurring early on and in an interesting stage in our program, and it's, you know, our goal to have it be as closely following the established, you know, peer-reviewed model that is in place, but also flexible toward like the environment that we're in right now. So
So when I go to the back, I saw a hand over here, and you can come back up.
Yeah, I just wanted to ask Mr. Drucker, what's the ongoing plans to ensure that Ms. Smith's unit stays clutter-free?
Thank you for that question. My organization's allowed to be the repee for tenants since we're not the landlord. So the plan is to engage some sort of ongoing housekeeping, but also since there's no bugs, the home health aide is willing to go into the apartment. The hours just got increased, so we've got some light housekeeping from them too.
How long is the grant for?
Good question. It expires at the end of September, this year. But it looks like there's part of ours is just been sort of working with the state and other things to sort of with our outcomes, and that's why the sort of, you know, but there's talk about an extension of it, which, you know, is obviously good news to us. But I think also for the providers, I think it's a good news too. So.
Here.
That kind of answered my question. I was at kind of, your flexibility is due, I think, in large part to your funding source. And I was just wondering how sustainable that feels right now, and what are other funding, will this eventually be Medicaid funded?
Possibly, yeah.
Probably leads to your success in a lot of ways.
Yeah, but I think that's where I think it's looking at what we have done and really promoting that to potential funders. That sort of flexibility of when you can do service delivery, how many people
So the
you're
session
seeing
is
and
over at
stuff.
12:15, so if you are leaving, if you can just leave a little quietly so we can continue.
So
Thank you.
yeah, that has been a big strength. So, Steve?
You mentioned getting texts. Have you
Yeah.
tried to get people cell phones
Yeah,
and get them a service so that they can use that?
Yeah, we do give cell phones to those who don't already have, and it's been very, very helpful. You know, we had talked when we first started this about giving people smartphones and other systems and stuff, but we thought we should start it with basic phones and just using it for basic text messaging and see where it would go.
So you pay for the service?
We pay for the service, yes. But it's one of those, I think, I'd have to talk to Zara, who gets the phones, but it's a plan that's affordable if we were to pull back. And again, so some of the questions before is that like later in the time of working with them, we would move the cost over to them. So,
Right. Many of the Safe Link plans are
yeah.
$30 a month for unlimited service.
The lady then.
My question is regarding the 15-day hospitalization, because what I'm finding is that hospitalizations are getting shorter and shorter. So, can it be a combination of hospitalizations? Because like the ACT team, like, you know, someone would have to have like 3 or more in a calendar year. Is that type of flexibility?
Yeah, it's totally that, and I think that you have to see as a reality, particularly for people in housing settings, that the city hospitals, people are in 5 days here, 10 days there. So we're not sitting there, oh, well, did they make it to day 15? And to enable us to see people in the hospital, we encourage the hospitals to refer earlier, so like day 2, so that we can go out, if they think the person's a repeat patient or has previously had long admissions, we'd ask them to refer to us sooner rather than waiting to day 15. So.
What is involved in the referral process?
The referral process, it's an application form, and if it's possible, a recent psych or psychosocial eval that a person has. I can leave my cards up here, and anyone who wants, we can email you referral forms.
So I'm going to go in the back and then here.
Yeah, I just wanted to say, it's really important, and Michael, just want to make sure I'm hearing you. Yeah, to really have all you guys bring great components and experience to the team. It's
psychiatric.
Psychiatric rehabilitation model.
Yeah, I mean, they put on this that it was CTI in a way, and the CTI, we're not following CTI in any way to the T. And it's really sort of something where we've, borrowed from here and taken different sort of forms of different sort of approaches. And a lot of it, again, because it's grant funded, there's been this flexibility to sort of tailor things to what appears to be working for us. And so that's why, like, some people will be discharged after, like, 2 months as opposed to following someone through for the 9 months. And some of that will be explored when we look about sort of our outcomes. Does that person end up readmitted to us and what have you, so.
And another question, how is that program going in Ireland?
Oh, the ACT program?
Yeah, how is that?
They have their own challenges over there, but it's, and they don't run with things as fast, but it was specifically an ACT team just to work with the homeless. And so they have a lot of housing issues as well.
Oh, I learned the Irish exam, but that's what
Okay. Yeah.
All right, so we're going to have our last question here.
I just wondered what's your caseload capacity and where you're at? Like, where's your cutoff?
Good question.
Very good question. We try to cap it at a max of 15 per staff. Peers have a smaller caseload because they spend a lot of time working with other people's caseloads. There's just been a turnover, so we average around 20 referrals a month. But our time interventions for different people mean that we haven't exceeded our caseload of 15 to 1.
So just want to again thank our panelists, and I'm sure they'll be here a little bit for more questions. Just gave a few more minutes just so.
Yes, yeah. Okay. Yes, yeah.
Yeah, I recognize you.
Next week, I don't. What day is it on? Can you email me the details? Yeah. Wednesday afternoon is an afternoon or morning?
That's why he gives his haircuts.
Yeah, myself, that's my work cell, so you can call me on that. Anyone, sorry?
How's it going?
UCS, Times Square. Oh, cool.
Okay.
What's your name?
We have, this is in the Bronx? Yeah. We've had 1 or 2 referrals from people going to BRC residents. So I'd love to talk more, because there's more we could be doing. Oh, thank you very much. Yeah, that'd be great. We come out and we can talk to your staff. So yeah, email me or I'll email you. Sure.
Mark can speak.
Okay, call me. There is talk. I feel like I'm just. There is the state and the city are going to fund it further. They are talking about Queens as a base. So, okay. Yeah.
Oh, no, CCS is the supportive housing, so I'm the case manager.
No, if it's a model, but if it's a model,
So we work inside that stuff.
again,
There are times it's but he's coming.
a lot of
It's permanent.
is that their primary diagnosis, or did they have a?
Yes, but I've had him come because I feel like my residents alone could get this whole program filled up.
There's always something else there before, depression, anxiety disorder, it's like mild MR or something. And that's not a barrier for us to go and work with them. It's when people come more moderate severe. It's that idea of like if we do any work for a
There's no other.
right?
Yeah, she definitely
But it's tricky because, again, I wouldn't want to say yes, of course, we would make referrals and then the time on the case of the nurse, the doctor, and the social worker in the hospital to please refer. Yeah, they don't. Joey. Okay, no, did you get mine?
Yeah, yeah, and who was the declutterer?
Kristen.
Yeah, we have to come out for
Yeah.
Okay, I know him.
Oh, yeah.
How'd you get hold of her? Oh, they know.
See if they have some more. This is the first time working with her.
Yeah.
We had a different one.
She told me yesterday, she's like, can I come here? Well, you know what?
There's more.
Thank you.
I think I have some questions to what she was asking, but I guess so I run a housing program for
I'll give you the right one.
Yeah.
with bigger communities. So they're living independently on their rent.
$95 an hour, and her assistant is
First
$45.
year, the tenuous funds.
That's over $1,000 a
Case
year.
managers for WWD, but
When you use APS, what happened?
Yeah.
without somebody to assist them.
What happened when APS came? That make it worse.
This was fun.
Just, they clean up some of the stuff.
I mean, technically, it buys the key from something away.
Lots and lots of books. And she's a worker.
You're gonna come to the Verity site later today?
I'd like to. Do you know who was in here who was asking me specific follow-up questions? Todd. Todd was in here, and he was asking, he's like, what do you plan for?
You have to have
And you know, I can make that more clear. That's a very okay.
So for individuals, but dual diagnosis, meaning BTD, and not necessarily, but it's dependent on.
Is it feasible after 9 months that you might be able to make it like we've done with the escort, try to be creative for them to get linked to videos. Can they manage some of it themselves if they have this intensive support for a period of time?
There's one friendly face out there.
Hey, look, I get it. That's why I also need to take a shot. Our cases is doing something. I've got to take a shot. This isn't going to work. But they've actually had more access, they've linked the molecules and it really works well. And so, I get it's not crystal ball.
Maybe I'll send referrals out and you guys can say yes or no.
It works out. I wish there was the easiest way in the future to run. Because they don't like to waste their time. But if you want to say,
However you want to think about it. I know.
Yeah, we
Talk through it too, and then starts at 1 and 1 starts
I don't work for the Justice Center, for United Cerebral Palsy.
okay.
In New York City, so yeah, I'm taking the information these days. But yeah, so there's mostly anti-traumatic so it's different, trying to see if we can do that. Cool.
Nice to meet you.
Thank you.
Good to see you.
Hey,
how are you?
Andrew Pearson, I'm coming up. I arrived a little late for these discussions. I was wondering a bit more about whether or not, because we get a lot of kids getting recently discharged from psychiatric centers. But and some of them have been there for longer than 2 weeks, but they've also been out for less than a period. Comes back from the hospital. Would those kids be eligible?
See you later. 18 plus.
Yeah.
They are, okay.
Yeah. Most of them, the overall majority are 18 to 21. Active.
They would be eligible, but they do this, I can email you a referral package.
Oh.
Give me a call, and
Okay.
talk to them more privileged.
That'd be great.
And if you have, say, someone in mind, as it's sort of the case, like, look, this guy came out, here's it.
Right.
And you can play it out that way and see.
That'd be great.
There wouldn't be a reason why. Like, if they come out, they've had that sort of, from a state, or no, a hospital setting.
Right.
And it's recent and stuff like that. Yeah.
Okay, that's great.
Give me a call.
I will.
Okay.
Thanks a
All
lot.
right, no problem.
Hey,
Hi, how are you doing? Good,
Oh,
good,
oh,
good.
good. So CCS is part of this, right?
Yeah.
I thought we were supposed to do some trainings for you guys,
They were.
right? And then something happened, someone was on maternity leave.
Yeah, not for me.
Oh, not for
They
you.
were supposed to do them for our help line.
Right,
Two.
right. Okay.
So
And who trained you on CTI?
I had CTI training before myself.
Yeah.
But it was,
Online or?
No. I did it back in Ireland. It's like through the university. But I'm not, I mean, that's why I just want to
Right,
see how
right,
many
right.
people.
Yeah, you just use
These
it
guys
as a
here put in this.
modified model.
In our proposal, I don't train in any way.
Right.
I don't want to train the science of CTI.
Right.
We're not.
Right.
As you heard.
Kind of just use it as a guide.
This is good. I like the idea of the 9 months and what we do in that first 3 months of that, and really putting that community together and being in the community with the person. And that level of communication and building up that network for a person. And people are talking, I mean, we've done this for years. Of Andrew talking to housing provider, Andrew talking to doctor. And so, yeah, on that scale. But, CTI, we talk to pharmacy materials in 9 months. We don't get that.
Yeah, but you guys get trained at these like MI for your staff?
Yes. But our these guys, we literally started in October. And we were basically got 30 for us.
How many cases has it? How many CTI workers? Whatever you call it.
We were 2 people, this age. And so we had 200 referrals in the last
I bet.
7 months.
No, it's like category B of the Indian, right?
And so, and you know what it is, a lot of those referrals didn't pan out for different reasons.
Right.
But we worked with each one in the sense we talked to the social worker, we were like, we was just like, no. So there were people who ended up longer term hospitalizations, people who had been, had act service in place. So we had like a whole mix. But, so our training basically came about, we haven't done like formalized training for all our staff, 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 formalized training for all our staff.